I'd like to move on now to our final speaker of the session. Reena Rajasuriar is a senior lecturer in the Department of Pharmacy, University of Malaya, and an adjunct research fellow at the Peter Doherty Institute in Melbourne. Reena originally studied pharmacy and then did a PhD in immunology. She currently coordinates a translational research program in HIV immunology at the Centre for Excellence for Research in AIDS and heads the Immunotherapeutics Laboratory at the University of Malaya. Her current research focuses on the immunopathogenesis of accelerated aging in people living with HIV, and today she's going to talk to us about healthy aging in people living with HIV. Thank you, Reena.
Thank you, Stephen. Thank you to the organizers for inviting me to speak today, and to all of you all for staying back to at this last session. So the topic I'm speaking on is on aging healthy in people living with HIV. I have no disclosures. This is my outline. I'll start by very briefly going through the changing demographics of people living with HIV, with some emphasis on what's still needed in the Asia-Pacific region to understand the demographics better. I'll then talk about functional aging in HIV, and which is a concept that I started talking about 2 years ago when we started doing studies on geriatric syndromes in HIV. It's not a new concept, but it's something borrowed from the field of geriatrics, which is very relevant to what we're seeing today in people living with HIV. And I hope through this I can convince you that we should be moving away from looking at chronic diseases as a surrogate for aging in people living with HIV to starting to look at more functional markers or geriatric syndromes. And finally, I'd like to introduce some community perspectives on growing old with HIV in Malaysia. And this is work that we did over the last 2 months. And I don't think there's, a lot of the times when we do research, we tend to do this from the perspective of the clinician or the researcher, but we don't really listen to the community. Unlike, I think in HIV-NAT, you've done that very well in terms of your prevention studies with Dr. Nitya leading a lot of these research. And it was something that we started doing and found that it was really very informative. So we've come a long way since the discovery of the virus. It's now 37 years, and over this time, since the introduction of antiretroviral therapy, that has completely changed the way that the face of the disease. It used to be seen as a condition which was known as a death sentence, and now it's a chronic manageable disease. And because of that, a lot of our patients are now living longer. And this is data from the Anthena cohort, modeling data from the Anthena cohort in the Netherlands, which essentially so by the year 2025, it is anticipated that 2 out of 3 people living with HIV in the Netherlands are going to be over the age of 50. And the demographics in the developing countries have always led the way. And in the Asia-Pacific region, we see that 1 in 3 individuals are going to be over the age of 50 years by 2025. And this is data from Treat Asia, which is an observational cohort which reports data from 21 different sites in the Asia-Pacific region. So it's a matter of time that we are all going to see our patients in clinic requiring more and more care. Now, the global burden of HIV in individuals over the age of 50 is not only contributed by people surviving longer over the age of 50, but it's also contributed by people being diagnosed by HIV in this particular age group. Now, a lot of the surveillance data that has come out recently in describing this increase in rates have largely been from resource rich settings, and there's really very limited data from low middle income countries. Now, this graph shows a recent study published from the surveillance data in Canada, and you can see, and it essentially analyzes the trends of new infections of HIV in people over the age of 50, shown in the yellow bars, compared to individuals younger than 50 years old, shown in the red bars. And you can see over the period of 10 years, there's an increase of 39%, as opposed to the red bars where you see it declining over the same period. Now, similar trends of increase have also been reported in other countries like the UK, Europe, and the US. And there's very limited data from the Asia-Pacific region, though we don't expect the numbers to be very high. What we've learned from prior reports is that the pattern of increase has been rather insidious, so it slowly occurs. And so if we're not watching these numbers carefully, then we may actually miss new infections or an increased rate of new infections in people living with HIV over the age of 50. And why this is important is because this population has been shown to have a higher mortality rate, short-term mortality rate, and they also tend to present much later. So it's just something to look at in our surveillance data in each of our countries. Now, as our patients are living longer, there's also an increase in the burden of multimorbidity. And this is data from the HIV cohort. And essentially in this study by Shorten, they explored the number of comorbidities or age-associated comorbidities in people living with HIV over the age of 45 years, as well as uninfected controls. And the comorbidity studied included cardiovascular disease, metabolic disease, pulmonary, renal, bone, and malignant diseases. Now, in this study, what they found was that the mean comorbidities, number of comorbidities in people living with HIV was significantly higher, especially in those in the age groups of over 50, compared to uninfected controls. If we look at rates of comorbidities in people living with HIV in the Asia-Pacific region, we also see fairly high numbers reported. Although the rates are quite different from country to country and disease to disease and dependent on the characteristics of the population studied, it's still fairly obvious that these rates are fairly high. Now, a limitation to a lot of the studies that we're doing in the Asia-Pacific region is that we're not comparing this to uninfected controls, and this is fairly important because background levels in the population can differ from country to country, and so we really need to do more studies comparing the rates of our comorbidities to uninfected controls or community controls. So what it appears to be happening is that antiretroviral therapy has done very well in terms of increasing the lifespans of our patients, but this unfortunately hasn't translated to an increase in health span. And health span classically has been defined as a period in which an individual is free of disability. And disability in this case includes both clinical status as well as the socio-environment that they live in. So how should we be measuring health in the setting of an aging HIV population? And at this point, I'd like to introduce the concept of functional aging. So aging is in fact a measure of an individual's functional capacity. And like it or not, as we grow older, we all will start to lose a little bit of function. We get a little bit tired walking up the stairs. We don't see very well. We don't hear very well. But the key feature about functional capacity is that it's highly variable from individual to individual. And we see examples of this in our daily lives. We see individuals at the age of 70 who can still run and complete marathons, but other people who can't get out of bed or who can't bath themselves or who can't eat themselves at the same age. So the functional age of individuals or the functional capacity of individuals are very different, and it is these aspects that we really should be trying to monitor or measure in our patients rather than the mere presence or absence of clinical comorbidities. So two individuals can have the same number of comorbidities but have very different trajectories of how they then grow old in terms of their functional capacity. Now, this concept of functional capacity is something that has been used for a long time by our geriatricians, and they have essentially developed a lot of the tools in order to help us measure this. Geriatric syndromes is essentially a condition that occurs as a result of accumulated deficits in multiple organs that renders an individual vulnerable to situational changes and stresses. Now, these conditions collectively include functional ability, metabolic, nutritional state, cognitive function, physical health, comorbidities, polypharmacy, sensory impairment, mental health, as well as social isolation of the social environment that the person lives in. So all of these encompass what is known as comprehensive geriatric assessments. And these assessments are done on a routine basis by geriatricians as part of their routine clinical follow-ups, and has been shown to be very useful in essentially extending disability-free survival in patients. A key feature about geriatric syndromes is that they tend to co-occur. Now, this is a very early study that was done by Meredith Green, one of the earliest studies to actually look at geriatric syndromes in people living with HIV. And you see that in the median age of 57 years, more than 50% of the cohort presented with at least 2 or more geriatric conditions. We have a lot of studies in the literature that have measured geriatric syndromes in people living with HIV, but this tends to be done on a single entity, which means we are only studying frailty, or we're only studying cognitive impairment, but we don't really understand how these conditions interact with one another and cause disability to the patient. So we recently undertook, not recently actually, now quite some time, undertook a study to explore the multidimensional aspects of aging in in people living with HIV in our clinic in University of Malaya Medical Center. Now, we invited all of our patients who were part of our routine care and clinic to participate in the study, and the inclusion criteria was age 25 and above, no reported acute illness, and on stable antiretroviral therapy for at least 12 months. Now, you may think that this is an aging study, why was the inclusion criteria 25? Well, it was rather an exploratory study at that point, because a lot of the studies that had talked about the presentation of the profile of aging in people living with HIV had come from developed country settings, and the understanding at that point was that patients living with HIV tend to present with comorbidities 10 years earlier compared to uninfected controls. But there are many risk factors that drive the presentation of diseases that are quite different in the developed setting versus the developing country setting. Immune activations are higher. We're exposed to more toxic antiretroviral drugs. Our presentations of diseases and AIDS defining illnesses are much higher in our population, and this could lead to an even earlier presentation of conditions. And so it was rather exploratory, and we decided to look at a much earlier age so that we could try to understand what the profile looked like. We also focused only on patients on stable antiretroviral therapy because we were trying to understand what were the incremental issues experienced by patients after they had been controlled in terms of the antiretroviral therapy. In terms of the we also recruited community controls, and they essentially came from volunteers in the community of the same age range, as well as friends of patients who, from our HIV-positive individuals. Now, we appreciate that the community controls in this case probably didn't have the same lifestyle factors as our HIV-positive patients, which has been shown to be very important in terms of a comparator group. But we need to understand that in a country like Malaysia, where being homosexual and being IDU are criminal offenses, it's really hard to recruit controls of these similar backgrounds for such studies. But we did try to enrich the cohort, the control cohort, with friends of our HIV-positive individuals, and all controls underwent rapid HIV tests prior to being included in the study. So we recruited 325 patients from our clinic, HIV-positive, and 290 controls, and there were 172 individuals matched for 172 pairs matched for age, sex, and ethnicity. Now, in all of our participants, we essentially did a range of assessments which encompass multiple domains, including general health, nutrition, neuropsychiatry, sensory, and physical function. And we essentially assessed the burden of geriatric conditions, and the burden of geriatric conditions were defined as a composite of the number of deficits that they had. So they could score anywhere between 0 to 10, depending on the number of deficits that they had. We also assessed health outcomes. We looked at VAX index, which is a mortality risk. We looked at healthcare utilization, which was a number of visits to any health facility in the last 12 months, as well as quality of life. And we compared the prevalence of the burden of geriatric conditions in the match cohort, which had a median age of 42. Now, in all of the geriatric conditions that we assessed, it was numerically higher in the HIV-infected compared to uninfected controls. When we looked at when we compared the number of geriatric conditions, which are 2 or more between the HIV-infected and uninfected controls, they were significantly higher in all age groups, even after we adjusted for traditional risk factors like smoking, alcohol consumption, employment, as well as education. We also then explored the association between an increasing burden of geriatric conditions and health outcomes. And in terms of quality of life, we saw that with an increasing burden of geriatric conditions, in both groups, the quality of life scores declined. But the decline in the HIV positive group was 2.5 times on average lower compared to the uninfected controls. In terms of healthcare utilization was 5 times higher in the HIV positive versus uninfected controls with increasing geriatric conditions. And in terms of mortality risk with VAX score, this was 4 times higher in the HIV positive compared to uninfected controls. We also explored risk factors associated with the burden of geriatric conditions, and what we found was that there were both social behavioral factors as well as clinical factors that were important, though the majority of factors were really social behavioral and lifestyle factors. In terms of clinical factors, low CD4-CD8 ratio and a history of AIDS-defining illness were independent factors. In terms of social behavioral factors, we found education level, unemployment, alcohol consumption, low physical activity, increased abdominal obesity, and social isolation to be important. So in terms of the lessons learned from this part of the project, essentially increased life expectancy in HIV is accompanied by a high burden of geriatric conditions, even in young, treated HIV-infected individuals. The increased burden of geriatric conditions had a significant impact on health outcomes, including mortality risks. Both social behavioral and HIV-related factors contributed to an increased burden of functional aging. And of course, this has significant implications in terms of the clinical management of patients. It essentially points that we need to have a multidisciplinary team approach when we manage our patients. Now, as I say this, I know it's a big ask for most clinicians in the room, because as it is in our clinics, we're overflowing with patients, we are dealing with so little resources, and it's really hard to get other disciplines to come in, or what is the best model of care, we don't even know that. But as we move forward, our patients are not getting younger, they are getting older. And so as we plan and as we evolve our clinical services, this is something that we really need to take into account, where we need to address not just the viral loads and the CD4s, but all the other factors as well. So I'd like to change gear a little bit and talk to you about some community perspectives on growing old with HIV. And this was from a patient participant involvement session that we had with a community-based organization in Kuala Lumpur. And to essentially understand what were the concerns of growing old in HIV in Malaysia with HIV in Malaysia was. So we sat down with 29 participants, and we included both young and old. So we had participants with an age range between 24 to 59 years. The mean duration they had been living with HIV was 7 years. All were males. Not sure why. It was an open invitation, and only the males came. And the group interviews were done in 4 sessions. with 5 to 7 individuals per session. And the way we did it was we initially had participants in the younger group. We used an age cutoff of 40, and an older group, those more than 40, sitting down, and we had a series of questions. But subsequently, we got everyone to come together, and we asked the same questions, and we got them to resolve a lot of what they were talking about and get to issues and prioritize issues which they felt that we needed to look at more. So what I'm going to present here is just one of the questions that we asked them, and it's, what are your main concerns about growing old? And there were 6 themes that came up as important in this particular discussion. And the first was increased dependence. Now, I think that's fair. All of us are worried about increased dependence as we grow old. But in the context of HIV, people living with HIV, essentially what their worries are that it's because they have poor or no network of family members. And I think in the Asian setting, this is very important because as we grow old, a lot in the Asian culture is you then live with your children or you have your family members who then will look after you. But in the context of the community that we spoke to, essentially they said that a lot of them are quite estranged from their family, and so as they grow older, they really worry about who's going to look after them because they don't have family members to look after them. The other issue was that there are very few aged care homes in Malaysia that will accept people living with HIV. I'm not quite sure what the situation is with other countries. I know Hong Kong has got an NGO that essentially runs aged care homes for people living with HIV, but I'm not aware of any other settings such as that. But in Malaysia, the situation is that most aged care homes will not accept people living with HIV. And so without family and without an opportunity or without options for going to aged care homes, it really makes the situation quite difficult. The second issue that they talked about was losing financial independence. And again, in the context of people living with HIV, this was how it was presented was that in Malaysia, HIV is not an insurable disease. So you can insure yourself for other conditions, but not HIV. And so while treatment or drugs are free, you do still have to pay for consultation and in some institutions also for lab tests. Although this is heavily subsidized, it is still seen as an out-of-pocket expense. And so for the community, this is a level of stress to them because this means that they have always to be gainfully employed in order to earn enough to pay for their medical coverage. And this is an aspect that I think also needs to be looked at. Long-term antiretroviral therapy effects. There was concerns around efficacy and resistance with taking multiple medications. So this is related to, I suppose, some of the polypharmacy issues that Tim talked about earlier in terms of drug interactions. A lot of the participants had been taking medications for a long time already, and they were concerned that over time, the efficacy of the drugs are going to decline, or if they start taking it with other medications, that's going to lead to a problem. And so that was one aspect that they talked about in terms of their concerns in terms of growing old and having to take a lot more medications for other conditions as they developed it, as they grew older. The other concern was in terms of ART-associated metabolic side effects. Now, a lot of, as I mentioned earlier, HIV itself is not an insurable disease, but a lot of them may have insurance for other conditions like cardiovascular and diabetes. But as more and more as the literature essentially supports that, or it suggests that antiretroviral therapy may lead to the development of cardiovascular disease and diabetes, their fear is that soon even those conditions that they're now able to get insurance for, they won't be able to then get purchase insurance, and that will be a problem for them. Death and dying. Now this is something that took our group by surprise. So they were concerned about the autonomy of keeping their status secret, particularly in the end of life, where in such conditions they may not have their HIV doctor with them, and it may be another health a discipline, another doctor from another discipline, which may not quite understand the issue around keeping their status secret, and particularly because a lot of them haven't disclosed this to their family. So this is, I suppose this relates to or resonates with some of the issues that Dr. Paul brought up yesterday in terms of mental health in HIV, where he talked about there are going to be issues in terms of palliative care advance directive that we need to start thinking about, and we need to start educating our healthcare professionals. Concerns around funeral arrangements. Now, in certain religious faiths in Malaysia, the way the body is handled during the funeral burial rites is different when you're HIV positive versus HIV negative. And what they worried about was that if the family members then see those rites being done differently, then it's going to be very obvious that they actually have HIV positive. So their worry was even in death that they cannot keep their status secret, that they're going to bring shame to the family. And so that was very sad for us to hear, but that was the reality of it. Mental health and cognitive issues, and these were issues, again, mental health is not something covered by insurance in Malaysia, though I think with a lot of government efforts, we've started to have one or two companies who have started to provide coverage just this year, but there's a lot more to be done. But the concerns were basically that they felt that in terms of treatment for mental health, they didn't get enough access because they were only referred to psychiatrists when the symptoms was very severe. And every time they see a psychiatrist, the modality of treatment is always medication, and there's very little options of getting talk therapy or counseling. And so they're very reluctant to keep taking more and more medication. So they feared, essentially, as we grow older and you will become depressed, how are we going to manage this issue? And finally, of course, loneliness and social isolation. They're all isolated from their family, and for them, the community is essentially their support system. But as they grow older, one by one, they know they're going to lose their family, their community. And in that circumstance, how are they supposed to sort of care for each other in terms of when they're less physically and cognitively abled? So those are the 6 themes that we essentially worked out, or rather put together from just that one question in one group discussion. And I guess some of the lessons that we learned was that there are significant discriminatory policies and practices that must be systematically addressed to promote a healthy aging environment for people living with HIV. It's not just assessing functional ability or cognitive ability. The whole environment of how they live in also needs to be looked at in terms of dealing with health insurance providers and lobbying stakeholders, speaking to aged care homes, looking at the governing policies, understanding the concerns of why they're not comfortable to open up care for people living with HIV, engaging with religious leaders. I think everyone needs to have a dignity even in death. And healthcare professionals, and this is something perhaps we can get more involved with in terms of talking about autonomy and confidentiality. It might be second nature for all of us who deal with people living with HIV all the time, but it may not be the same for other disciplines, and how do they then tackle these issues, particularly when there's no family member around in situations of end of life. Economic evaluation studies on growing old with HIV is probably very important to lobby government in terms of getting more funding. If healthcare insurance or private healthcare insurance is not accessible, then the government needs to step in. And for that, we need data, and it's us, the researchers, who have to get this data for this. and studies on the impact of polypharmacy in older population, because this is a real fear and they don't want to take more medications because they feel that that's going to lead to a decline in the efficacy of the drugs that they're taking. So I think a lot of the studies that we've done is in younger populations looking at drug-drug interactions, but we need to start looking at the older population, and particularly from this region. We don't really have a lot of studies from this region on polypharmacy. Thank you.